Well, good afternoon. This is State Representative Paul Baumbach. I serve the 23rd House District, the Greater Newark area, west and north, and I'm also a co-chair of the Delaware Retirement Health Benefits Advisory Subcommittee. And it is time for another installment of just a discussion on where Delaware stands in its process to review the best approach for health benefits for our state retirees, both today and tomorrow. So thank you for joining me. And I want to point out that these segments are recorded on Facebook, and also I store them on my YouTube page and have them available there for those who are not a part of Facebook. So that's available for you. I did not have this event last Sunday. I still was recovering from a foot surgery. So it has been 2 weeks since I've done this. And that can sort of bring us to a meeting that we had a week and a half ago, the first meeting of the RHBAS. So with that, I want to bring up the presentation. So this is a presentation from March 6th. And I'll just go slide by slide through it and see how that goes. Just go one at a time. There we go, one at a time. So at the committee, this was presented. This is the materials that went with the meeting. The meetings are public meetings. They're on the Delaware Public Meeting Calendar. You can always Google search that, look it up. And the agenda is posted a week ahead of time. It can be adjusted after that. In addition, the materials for the meeting are posted at least concurrently, hopefully a little bit in advance of the meeting. So this is the file that's loaded up that's available from that meeting on the page there. So it points out what set up the subcommittee, what its tasks are. And I want to read this first section. Conduct public meetings, receive public comment about current and future state retiree health care benefits, including the previously proposed Medicare Advantage plan for state retirees, while taking in consideration the previous work of the State Employee Benefits Committee and the Retirement Benefits Study Committee. And I want to talk a little bit about public meetings and public comment, because that was one of the issues that came up during the meeting on the 6th. So a public meeting in Delaware is one that's open to the public. Well, actually, we've passed some laws to make sure it does require opportunities for public comment, but it does not mean that it is a public discussion. So it is one that, again, offers the public availability to submit comments either in person, verbally, or in writing, or remotely. And again, the meetings are open to the public, so the public can attend, see it, and view that. And Abe, I'll get to that link to where you can find this presentation. But it does not mean that we must have an ability for members of the public, and a series of them, to ask questions and have their questions answered during those subcommittee meetings, during that public meeting. That said, we also know from the past 6 or 8 months that the public members of the public have a lot of very deeply held concerns with the path that was taken last year and the year before by the state, and the proposal for the Medicare Advantage plan for state retirees. We know that because we've had multiple public hearings with a lot of feedback from retirees. So there's no question that there's a lot to be shared. And I'll say it, speaking for myself as one of the subcommittee members, I think we're quite aware of this, but it doesn't mean that we don't want to have opportunities for more submission of these public views. And some of those submissions may include not only your viewpoint, but also your questions. And I know that I get a good number of emails with questions, and where I can, as it relates to retiree healthcare benefits, whether you're in my district or not, I will strive to address them, especially if I don't think that they're otherwise addressed. So, and one of the questions has been about public meetings, so I want to take a little bit of time to talk about this point one. So another thing, if you jump down to the last bullet, it's that this subcommittee is to share findings and recommendations by May 1st, which is just less than 2 months away, which is a very short time frame. And the reason for that is if we are to make a change uh, for what the state does for retirees as of January 1st of next year, then it needs to be in the budget. And the budget is finalized by June 30th, and it takes several weeks between what you want to do and getting it into the budget and passed. So that May 1st is a good goal date to have recommendations to the extent that it has a budgetary impact, and any changes to state retiree health benefits is going to have a budgetary impact. So that's the reason for that timeline, but it also puts us on a really tight timetable, which is another reason that we, as a subcommittee, need to be very mindful of making sure we get through a lot of the facts and figures and the research, in addition to having opportunities for public comment. So I will go on to the next slide then. It talks some background, how many people are covered by this, over 30,000. MedicFill is the current retiree health benefit program. It serves as a Medicare supplement, and it's administered by Highmark. But we are self-insured, so we pay whatever the dollars are. So if it's a healthy year, we don't pay as much. If it's an unhealthy year, we pay more. The contract ended December 31st of last year, and it was the SEBC, the State Employee Benefit Committee, chose and contracted for a replacement with a Medicare Advantage plan that was custom to Delaware, but Superior Court Justice halted that, and so instead, and directed that the state ensure that the MedicFill program was instead offered for this calendar year. But that leaves a lot of questions as to what happens as of December 31st of this year. And things are still in the courts. So at this point, there's uncertainty. And frankly, I'd like to have that uncertainty clarified in the next RHBAS meeting, Retiree Health Benefits Advisory Subcommittee, both for what happens if the courts say that was essentially a temporary stay, or at least that's how I view it, a permanent decision by the courts, and I think there's appeals going on and such. If the decision by the courts is we as a state are not permitted to go to a Medicare Advantage plan, then we need to figure out what we do with that. If they say, oh, that stay should end as of December 31st, and you can do whatever you want as long as you do it through the right procedures, then we need to figure out what to do, including having Medicare Advantage as one of the possibilities. But I don't want to make assumptions there. I want to find out from the attorneys from attorneys and from, I'm going to say, independent attorneys, where we stand and what our choices are there. So that's where we are today, and we're trying to figure out what we have to do tomorrow. So it is expensive from what we do with MedicFill. And so extending this over what had been planned with the Medicare Advantage costs somewhere on the order of, I think, somewhere around $7 or $8 million a month, in addition to what it would have cost. So that's a big cost, and that's what we're paying now. So that's one reason why we want to look at this. But more importantly, we've got a very big deficit. I'm sorry, we're going to see the deficit in a minute. This slide shows a bunch of costs. Now, at the meeting, it was pointed out that this third row, which shows what Medicare retirees and pensioners pay as far as what part of the premium is paid by them, this does not show it. It was one of the members of the public, or maybe a member of the committee, pointed out that this does not show the full costs that are being paid. As an example, a current employee who's paying 18% of the premiums, that's 18% of the healthcare costs. But a retiree, while they're only paying less than 1% on average of the premium that the state pays, that doesn't reflect the perhaps 40 years, lots of years they paid into Medicare during their working lives, and for the amount that they pay into Social Security and Medicare as a retiree. This is only looking at what portion of the state premium, state healthcare costs, is being paid by the recipient. In the case of the third row, we're talking about retirees. Also pointed out these columns and such are not well labeled, not well presented. The 1.2 billion includes both the amount paid by the state and by the recipient, or I should say the employee or retiree. So it's not a great display, and that was made clear at the May 6th meeting. So there's more stuff as far as how Medicare and MedicFill work together, and with prescriptions and without. So some details was presented there. There are different costs depending for retirees, different costs based on how many years of work you've had with the state, and that changes depending on when you retired, how many years ago, because there were changes in the law for how much you're responsible for and how much the state's responsible for. Again, the cost of what the state pays for those who are retired for their health care has gone up year by year. There's been steps the state's taken to control those costs, and they've slowed things, but they haven't prevented the overall strong increase in costs, nearly doubling the past 15 years. And this is where I mentioned briefly the gap, the funding gap. Perhaps that's the easiest way to describe it. It was measured at 10 million maybe a year ago. With the rise in interest rates, the change in discount rates, that's come down to around 9 or 8.4 billion. It changes because it's based on numbers. It's based on things like interest rates that change daily. But in that order of magnitude of high single digits of billions of dollars. So it's gigantic. It has grown over decades, and it's not something that's going to be fixed in a year or two. It will take decades to fix. But the goal of policymakers is to identify a path that we can address that over the coming decades, but identify that path, adopt that path, and get on that path as soon as possible. Again, costs keep going up, and we can't. And this is for both retirees and current employees. So it's not a single problem with just retirees. This is a broader problem. The RVHAS is focused solely on retiree health benefits. So it makes sense that there are 3 different ways to attack this problem. You can put it on the shoulders of taxpayers, put it on the shoulders of current employees, and put it on the shoulders of retired employees, or more likely put it on a combination of those 3. So you have a column for each of those 3 categories. I'd like to stress, and I put this in an email to somebody who asked a question, this is not, I don't view this as an exhaustive list under each column. As an example, there's nothing in current and future retirees that talks about having options or having grandfathering, depending on whether they're already using MedicFill and would like to continue using a Medicare supplement, as opposed to making Medicare Advantage required for new retirees, things like that. That I view that as being in the column, even if it's not a specific bullet on there. But again, we can put any, all, or none of the steps to address this funding shortfall on taxpayers, on current and future retirees, on active employees. Again, combination is probably the most sensible of those 3, as opposed to having it all on the shoulders of one. Yes, there's a bunch of states that have gone to Medicare Advantage at least as an option, not necessarily as the only option, as a required step. Let's say 30% of states offer one or more as a choice along with the supplement. Or 30% offer it as a choice. And that's one of the things we've heard a lot from retirees is, we don't mind if you offer Medicare Advantage, just don't force me. I may have a reason to really not want it. And that's a path that we know is desired by many. So next one. So we have a meeting this Thursday at 10 a.m. It will be live streamed, also in person down in Dover. We're looking at 1 or 2 meetings next week, the following week. That's not yet set. If anything is going to occur the following week before Thursday, it'll be announced at least a week ahead of time. And if so, it would be also announced at this Thursday's meeting. And if there's also a specific subcommittee meeting next week, the following week, not this upcoming week, but the next week, that will also be announced later this week. And then we open it up to questions. That's all the presentations we had at that March 6th meeting. So want to get that information out there. Now let's get to what we're going to do here. There we go. So I'm going to bring this page over, and we were asked how do I find this information? So I'm going to put in here. So at this web address that I'm putting up there, that has information on the SEBC, the State Employee Benefit Committee, and it has a section on the subcommittees. And say, I want to find out about I want to view the Retiree Health Care Benefits Advisory Subcommittee members. You can do that. You can get the full list of all of them, including their email addresses. So if you have specific questions, you can send your questions to one or a combination or all of the subcommittee members. It may be that we will develop a specific email address that you can send a single email and it will be then distributed to all the members. We don't have that right at this point. Perhaps this week we will. You can, let me see, you can look at the public comment. Did the members view the subcommittee members? That certainly looks like the same thing. Retiree healthcare. Oh, there's two different subcommittees listed. So we've got this one here. Now, what I want to look at is if we go to, so that was just the members. All right. Then if I come back, calendar. So if I go back to March 6th and I look through, and we had the SEBC, but we also had the Retiree Health Benefits Advisory Subcommittee, and I click on that. And this is so crazy. It does not like me to go down and pull up the address. So let me see if I can get it this way. There we go. So we're going to come here. And here what I did is I did a Google search on the Retiree Health, actually the Delaware, sorry, tell you what, let me show it to you. So I'm going to put in here, Delaware State Employee, it's not showing yet. That didn't help because I didn't have my screen up, huh? Okay, so I'm doing a search for Delaware State Employee Benefits Subcommittee materials. How's that for something specific? And if I put that in there and I do here, then I can get the March 6th, the agenda, and the briefing is the handouts. And there's two of them. One is all the rules about a public meeting, but the other one here is the presentation I showed you, going through all the different pieces. So again, I Google searched Delaware State Employee Benefits Subcommittee materials, and that's how I got to the page from which I could get all the meeting materials. And you can see that the agenda for Thursday has been presented. So we will be reviewing the minutes. We'll review different Medicare options across the states. We'll look at what the past subcommittee that looked into this, what was known as the Retirement Benefits Study Committee, what it looked at. It had two different reports that came out, one in 2021, one in 2022. So we can go over their work and then come up with a plan for March and April ahead of our May 1st deadline, and then open discussion from members and then public comment, and have all of this achieved between 10 a.m. and noon this Thursday. And you have the address of where you can go and be in person, and also a link for how to join a Microsoft Teams virtual meeting version of it. So that is all there under the materials, which comes from the subcommittee materials page from doing that Google search. Did that all make sense? Now, what was the, okay, so we've got, you can also Google search Delaware Public Meeting Calendar, and click on that. You can put in whatever you want. So you can put in the SEBC, which is the State Employee Benefit Committee. You can do a search on that, and what you find is it defaults to a 20-year period, which is probably broader than you want. So maybe if you say, I just want to look for January through this year, January through April of this year, and three, and then you'll see all the SEBC meetings, including the subcommittees for health planning and financial, but also also the health benefits subcommittee. You'll see those meetings in here. You can click on that, and then and that will show you that'll show you what any agendas that are listed, any meeting materials if they're already posted. All right, another question. So we got ABES. I posted two things. Okay, Lynn, why did the state not address this growing deficit? Why weren't less drastic measures taken much sooner? I'm going to take that thing off there. It seems our money should have been taken care of. Lynn, you asked a great question. Let me give some context on this. This very large funding gap, as I said, has grown over decades, not in obscurity as far as it's been there. But one thing that's changed is financial reporting rules have changed. So just in the past, I think 3 years, the organization, I'm blanking on it, but there's an organization that sets the rules for financial reporting for nonprofits, and they changed and said, you used to just put a footnote saying what your retiree benefits are if you're, say, a government, but now you need to bring it forward and make it much more obvious. And with it being more obvious, it's now looked at more closely by our bond rating organizations out of New York, the AM Best and Moody's and S&P, and the presence of a large underfunded obligation like this leads those agencies to look more critically at the entity, in this case, the state of Delaware. We're one of, I think, maybe 10 states or so that has maintained a AAA bond rating through all the financial challenges the past many years. And this challenges that. This risks the state being downgraded to, say, AA or single A. And that would come at a big cost to taxpayers for the interest rate that we have to pay for money that we borrow for instance, our roads and bridges and schools and such. So that has brought to the front the need to stop kicking this can down the road. In addition, we've had other big issues that we've been dealing with, and these multi-decade problems that take multi-decades to address. An earlier one was our pension system. Like probably most governments, this was a footnote for the longest time, and then its reporting requirements were raised, and then the state got serious about it and said we need to get on a road to recovery for that, multi-decade approach for that. And while we were dealing with that, we really didn't have the extra financial resources to also proactively take care of this, and it wasn't an emergency. So that's a weak excuse, but that's some of the background for why it was not addressed effectively. It wasn't really addressed. Some money was going towards it, but really almost a rounding error. So that's some of the historical background, but that's also one of the reasons why there is a present recognition that that's done. That past is past, and we've got to be addressing the present and future. But indeed, Lynn, you're completely correct in your frustration there. So Terry asked, slide 5. Okay, so that means I need to bring up slide 5 now, doesn't it? Okay, so Terry, I'm going to bring this slide up. So, okay. It's very problematic and should not be used. I'm sorry for posting it, but sorry for presenting it, but in fielding your point, I want to have it up there. As far as I know, it represents the entire cost to employees, so perhaps reflects an accurate percentage for them. It does not represent the entire cost to retirees, so it's not accurate. Terry, you're absolutely right, and I tried to describe that here. This is talking of this. This is the state healthcare cost. This is not the overall healthcare cost. It's not the overall healthcare cost to pensioners. Frankly, it's not the overall healthcare cost for current employees. It doesn't include, for instance, their deductibles and co-payments. This is looking really at the premium costs and the total that is paid by the state and by the covered individual. And it is talking purely about the insurance costs that the state has a role in. So the state doesn't pay Medicare premiums, and therefore the payment of Medicare premiums is not included in this slide. So as I said, this slide is poorly labeled, and frankly, this slide, which probably has 100 words in it, sort of requires a 300-word footnote explanation for the context in which it should be taken. And as such, I would agree with you. It is poorly and very liable for misunderstanding, and that is, I would agree, it's not good. And there's apples oranges involved there. Absolutely, it is intended by whoever drafted it in a very narrow use, and it within that narrow context, it is largely proper, still with some weaknesses, but it is can easily and reasonably be viewed as quite misleading and providing an apples oranges presentation. So Terry, I agree with you there. Okay, so I'm going to take that off because it understandably is frustrating. Susan asked, just curious, any consideration being given to providing improving access to healthcare counselors that can help advocate for the individual consumer? Someone look after individual healthcare history and help determine best plan options may calm a lot of fears. I believe that HMOs have a negative reputation. Susan, great question. And it's a broad question. It's not solely under RHBAS. It's bigger than that. Interestingly, I learn things in this job every day. The insurance commissioner's office has a group that works directly for you, for retirees, in helping to choose their Medicare package. If you reach out to them, they're available for that, to help you navigate amongst the plans and choose them. Related to this, when the state was, before the judge issued their ruling, while it seemed like we were moving towards Medicare Advantage, the state negotiated with Highmark and requested and received agreement to have a fairly unique set of advisors within Highmark, paid by Highmark, that would help the covered individuals work through things like pre-authorizations and network to find the doctor and a network for the services. And then the legislators in October crafted, a bill that would create, not outside of Highmark, create a group within state government to do really the same thing, to help our individual retirees in navigating through the system that we thought was going to be, at the time, was going to be effective as of January of this year. So that providing assistance on navigating through whatever plan you have is indeed recognized as a necessary piece. And we've got a piece of that within many healthcare insurance plans. Selecting a particular Medicare Advantage, Medicare supplement plan is something that is offered under the insurance commissioner's office. The actual issue that I think, the broader issue that you're raising, Susan, is that doing a case management, helping individuals knowing their full medical situation and guiding them in ways that will help their health results, is something that we often we'd like to put that on the primary care physician as sort of the quarterback of that effort. But we also have a primary care physician shortage statewide, and we're just really, they're often very tight on time. So it's very challenging, and we're not doing it well. We've got different groups that, for instance, within our Medicaid system, I think there's known as MCOs, managed care organizations. I think some of them have some models that they've are working on to help do that more holistic view of the individual and their health history, to help them really synchronize the different pieces of health services that they're receiving and eligible for. There's, as far as the negative reputations, I'll just give my personal reputation. I was going to say sample size of one. I'm a state employee, eligible for eligible for choices amongst the different healthcare plans the state offers for its current employees. I switched at one point to an HMO based on the premium cost being low and looking like, oh, this looks pretty good. And frankly, 1 or 2 years of going through the prior authorization and in-network and all that sort of stuff I personally wasn't a big fan of it. And so I switched back to a PPO, preferred provider organization. That is cost. It's cost different, has different out-of-pocket requirements and such. But it got rid of the prior authorization requirement, and frankly, in my recent experience in my foot surgery, did not mind not having to go through the prior authorization hoops on that. I get that different plan structures have strengths and weaknesses, and the navigation through HMOs and through prior authorization steps is understandably frustrating to many. Can I get the numbers of that slide to add up no matter what I do, Terry? Terry, during the meeting, I'm doing calculations myself. I'm sorry, I'm jumping from question to question, trying to go from first to last. But let me bring this up. You're completely correct. Math doesn't work. The argument was this 163 equals the sum of these three. I think that's correct. The argument is that piece plus these three pieces. That didn't work. You're not seeing this. 163 equals the sum of these three in this column. That 163 plus these three boxes supposedly equals 1.2. It doesn't. It's 1.1. And it's actually like 1.59 or something, rounds up to 1.1. You're right. The math doesn't exist. Let's just say this is not a good slide. So that's Terry. Does the state pay the employee part of their insurance? So yeah, the state pays a portion of it. I think somewhere around 81.7%, so call it 82%. And then the employee pays somewhere around 18% of the insurance premiums for state employees, and it depends on which program you have. So yes, state employees have a co-pay on the premium, and then often per visit pay for HMOs or percentages for PPOs and things like that. Maybe you talk about that slide. Gosh, Terry, I tell you, that slide it's gonna be infamous. Anyway, I'm not seeing more questions, and I think my dog is a little bit anxious. But I want you, if you can, please catch this Thursday morning's 10 to noon meeting of RHPAS, and either in person or virtually. I will likely be setting a time next Sunday to review things. I'm imagining there's going to be 1 or 2 meetings next week, the following week, this week and next week. The following week, I think there's going to be 1 to 2 meetings. We in the subcommittee are working to balance the dual mandates, if you will, of giving opportunities for the public to express their views, raise their questions, but also to ensure that the subcommittee gets enough information to come up with meaningful, actionable recommendations and findings for the legislature and the governor. So I think that's it. Please, my email is at the top of this list. Don't hesitate to reach out. I will say that, especially when we're in session last week, this week, it is challenging to get to everything. So I'm not turning around my emails and responses as fast as I can. There are emails that understandably I got from retirees who are very frustrated and are simply, please don't change my insurance. Please don't go to Medicare Advantage. If there's not a question, if there's not something for me to research, I'm likely not going to respond to that. If there's a specific question in there, if I can, I will get to it and respond to it, but I can't promise any specific turnaround. We're juggling an awful lot of things these days. But I want to thank you for your patience. I want to thank you for your involvement. Please continue that if you can. I don't need to tell you how important this is to you, of what we do, what we recommend, and what is acted upon. So Thank you very much. Have a great rest of your day, and I will likely catch up with you next Sunday. Take care.